Yes, Jerry.
Yes, sir. Thank you, sir. Good evening to all. Today's we'll be discussing on the role of or the use of steroids in neurointensive care unit. So we'll just start with some basic physiology. So as we all know, the adrenal gland is the source of corticosteroids, and the adrenal gland has a cortex and a medulla, and the cortex produces the steroids, and hence it is called as corticosteroids. Histologically, adrenal gland is divided into three zones. The adrenal cortex is divided into three zones: the zona glomerulosa, fasciculata, and reticularis. The zona glomerulosa produces mineralocorticoids. Fasciculata is responsible for producing glucocorticoids, and zona reticularis produces androgen precursors and few androgens also. So the zona in the mineralocorticoids are the hormones like aldosterone and deoxycorticosterone, and basically they are involved in fluid and electrolyte balance. And glucocorticoids includes cortisol, cortisone, and other drugs, and these are mainly involved in, they are called glucocorticoids because they are involved in carbohydrate metabolism. And there are specific enzymes in the particular histological zones, which is why zona glomerulosa produces mineralocorticoids and fasciculata produces glucocorticoids. Coming to the synthesis of steroids, corticosteroids, the precursor is cholesterol, and cholesterol will be converted to pregnenolone. So it is mediated by the enzyme cholesterol desmolase, and it is a rate-limiting enzyme. So from here, certain enzymes are specific for particular histological zone. So 17-alpha hydroxylase is present only in the zona fasciculata. So that's why pregnenolone is acted upon by 17-alpha hydroxylase, and finally cortisol is produced in the zona reticulosa. Similar fasciculate. So similarly, after forming pregnenolone in the zona glomerulosa, it is converted by 3-beta hydroxysteroid dehydrogenase to progesterone, then 21 hydroxylation and 11-beta hydroxylation. Then it produces corticosterone, and next comes the rate-limiting enzyme, the aldosterone synthase. Then, so corticosterone gets converted to aldosterone in the zona glomerulosa. So, coming to the regulation of corticosteroid synthesis, basically, cortisol synthesis is regulated by the pituitary, which is the ACTH hormone, which is secreted by the pituitary, and it is under a negative feedback. That's higher doses of cortisol will cause decreased secretion of corticotropin releasing hormone, and hence subsequently ACTH also. Coming to aldosterone secretion is predominantly under the influence of three factors, mainly the angiotensinogen and the extracellular fluid potassium levels, and slight amounts by ACTH also. Now, the mechanism of action of corticosteroids. So, the mechanism, steroids. There are basically glucocorticoid and mineralocorticoid receptors which are present in the cytoplasm. So this cortisol in the blood will be binding. It will be bound to cortisol binding globally, and subsequently it enters the cytosol, and where it binds to the glucocorticoid receptors. Glucocorticoid receptors will be found in an inactive form where it is bound to HSP70, heat shock protein 70, and HSP90. So once the cortisol binds to glucocorticoid receptor, it gets activated. Then there will be configuration changes in the glucocorticoid receptors. The next step is the translocation into the nucleus. So the glucocorticoid and glucocorticoid receptor and the cortisol complex enters the nucleus, and there the next step is it binds to specific gene sequences. So usually it binds to glucocorticoid response elements, and after binding to that, the next step starts, but either it goes to transcription or it goes to repression of the gene. So subsequently transcription, then translation of the transcription, then translation, and finally protein synthesis happens. So mineralocorticoids has diverse actions, and multiple proteins are synthesized, and hence it has multiple actions. However, mineralocorticoids has a restricted role, and mostly mineralocorticoids and glucocorticoids share homology. They almost have the similar structure, they differ in few sequences only. So there are chances that cortisol at higher level cortisol can bind to mineralocorticoid receptors, and it can produce a mineralocorticoid action also. So studies have shown that in vitro mineralocorticoid receptor, it has an equal affinity for aldosterone, corticosterone, and cortisol. So aldosterone receptors are present in the aldosterone receptors are present in the kidney, salivary glands, and epithelial cells also. So when cortisol reaches in those specific area, there is always a chance that the cortisol can bind to the mineralocorticoid receptor, and it can produce a mineralocorticoid action. So it is prevented by a pre-receptor metabolism. This happens in the kidney, epithelial cells, or the salivary glands. Here what happens is that the cortisol will be converted to an inactive form, cortisone. So this is by the enzyme 11 beta HSD2 enzyme. So 11 beta HSD2 enzyme. So how does glucocorticoids exert its anti-inflammatory action? So there are multiple mechanisms are there. One among them is the trans-repressive effects. So here you can see that the cortisol binds to the glucocorticoid receptor. Then then there is an activator complex called there is an activator complex. So it has a C force and C junction. This activator complex itself can bind to the gene, and it can produce an inflammatory cytokine response. What the glucocorticoid, the receptor, after binding to the cortisol, binds to the C-gen component of the coactivator complex, and hence it represses the transcription of that particular, and hence it causes a transcription and translation into another protein called IKB, which actually binds to NFKB, which NFKB is a pro-inflammatory complex. So inflammatory action is suppressed. The other mechanism is protein-protein interaction. That is the glucocorticoid receptor and the steroid complex. It can bind to the NFKB, the transcriptional proteins, and hence the transcription and translation of the NFKB is inhibited. The other mechanism is that there is a competition between the NFKB for binding with the coactivator complex between the glucocorticoid receptor cortisol and the coactivator complex. So when there is more amount of glucocorticoid receptor, this competitive inhibition can result in decreased action of the NFKB protein. The other mechanism is that it causes a negative regulation of the genes, basically COX-2, inducible nitric oxide synthase, and other cytokines, and it also inhibits monocyte differentiation also. The cortisol metabolism, it's very important. Cortisol is the active form. In the cortisol is converted to cortisone. Cortisone is the inactive form. It does not have a mineralocorticoid or glucocorticoid receptor action, and this is mediated by 11 beta HSD2 enzyme, which is present in the liver. And similarly, cortisone it is an isoenzyme. So cortisone will be converted to cortisol. Cortisone will be converted to cortisol by 11 beta HSD1 enzyme, which is present in the liver. So the oral formulations of hydrocortisone, etc., are in the inactive form, and this will be converted to cortisol by the enzyme 11 beta HSD1, which is present in the liver. So what are the effects of glucocorticoids? So it has multiple actions in various systems. Glucocorticoids are called glucocorticoids because they have an effect on carbohydrate or lipid metabolism. Basically, they causes an overall diabetogenic effect. It increases the hepatic glycogen deposition, increases peripheral insulin resistance, increases gluconeogenesis, and increases free fatty acid formations. Also, it causes adipocyte differentiation and promotes visceral obesity. And in coming to bone and calcium metabolism, it decreases bone formation by decreasing the activity of osteoblast, and it can cause decrease in bone mass and osteoporosis. And the one of the dreaded complication is osteonecrosis, avascular osteonecrosis with steroid therapy. Now, with skin, the action on skin muscular connective tissue is it promotes catabolism and collagen breakdown, and it can cause skin thinning and muscular atrophy. In GI tract, it can cause peptic ulcerations. In eye, it can cause glaucoma, and there is also increased risk of cataract formation. Then in cardiovascular renal system, it can cause hypertension, because it increases the it causes a permissive action. The response of catecholamines and others will be exaggerated in presence of glucocorticoids. And also because when there is increase in cortisol, it can activate the mineralocorticoid receptors, and hence it can cause a salt and water retention also. Similarly, with respect to immune system, it can cause an anti-inflammatory action and an immune suppression. So basically, the physiological action of glucocorticoids can become the adverse effects or the side effects when these are used at a higher dose, or when it is administered for long. So coming to the various therapeutic corticosteroids, these are the multiple corticosteroids which are available. Basically, these are all derived from cortisol, and hydrocortisone is the corresponding oral drug for cortisol. Hydrocortisone will be activated to cortisol by the enzyme 11-beta-HSD2, which is present in the liver. And these modifications in the cortisol will result in newer synthetic corticosteroids, which has different glucocorticoid potencies and mineralocorticoid potencies. So coming to relative potencies of different corticosteroid drugs, the hydrocortisone is the standard drug, or the cortisol. Cortisone, the anti-inflammatory, so it is compared with hydrocortisone is the standard drug, to which other drugs are the potencies are compared. Cortisone, it is slightly less potent. The fludrocortisone, the thing is that it has the maximum mineralocorticoid action. It has 125 times more potent than hydrocortisone. Prednisolone is 4 times more potent in glucocorticoid action, and methylprednisolone is 5 times more. And beta-methasone and dexamethasone is 25 times more potent in glucocorticoid action. Beta-methasone and dexamethasone, they don't have a mineralocorticoid action. Coming to duration of action, the hydrocortisone and cortisone, they are short acting. Usually the duration of action is around 8 to 12 hours. The other one, fludrocortisone to methylprednisolone, they are intermediate acting, acts for around 12 to 36 hours. And beta-methasone and dexamethasone around for 26 to 72 hours. No other one of the other side effects or the with chronic steroid use is HPA axis suppression. In the previous slide, I have told that corticosteroids secretion is under negative feedback when there is increased steroid production. When there is more amount of steroids are produced, there is the subsequent production of ACTH will be reduced. So usually this happens with supraphysiological doses, and any patient who receives more than 7.5 milligram of prednisolone for more than 3 weeks, we should anticipate HPA axis suppression. And along with that, the timing of administration of steroid also matters. A higher dose, like if the patient is totally receiving 7.5 milligram a day, if the patient is receiving 5 milligram in the evening and 2.5 milligram in the morning, there is more chance of HPA axis suppression, HPA axis suppression. However, if it is 2.5 milligram in the evening and 5 milligram in the morning, the chances of HPA axis suppression will be less. And so any patient who is suspected to or anticipated to have an HPA axis suppression, once the clinical effect has been achieved and once we are decided to withdraw steroids, we should not abruptly stop the steroids. A gradual tapering is needed because it can cause Addisonian crisis when there is rapid withdrawal of steroids. So coming to the uses of steroids, so one of the most common is in brain tumor. So as we all know that you can see there is an extensive vasogenic edema. And the first use of cortisone was by Ingraham to treat cerebral edema, which developed in patients after the surgery. And in 1957, Kaufman used prednisone for peritumoral edema associated with intracranial malignancies. So in 1959, a neurosurgeon, Dr. Joseph Galsey, administered dexamethasone 40 milligram through the carotid artery to a hemiparetic semi-comatose patient with a large glioblastoma. And the patient made a dramatic recovery, regaining consciousness the next morning, with the hemiparesis resolving over the next 4 days. So subsequently, a trial was conducted, and in that trial, dexamethasone was used in the treatment of cerebral edema associated with brain tumors. In that, out of which 14 patients who received dexamethasone, 13 of them had significant neurological improvement after administration of dexamethasone. So by default, dexamethasone becomes a drug of choice in neuro-oncology because it has a longer half-life, it doesn't have a mineralocorticoid activity, and it has a low tendency to induce a psychosis. So multiple studies have shown the efficacy of dexamethasone in tumor-associated edema. So it can be used before surgery, during surgery, and when the patient is receiving chemotherapy or radiotherapy also. And studies have shown that 70% of them symptomatically improve in cerebral metastasis with dexamethasone therapy. Dexamethasone, when started before elective surgery, usually 1 to 2 days, they improve the clinical condition by the time of craniotomy. Usually, clinical response can occur within 24 hours, but the raised ICP may not be consistently lower until 2 to 4 days after the initial dosing. So how does dexamethasone or corticosteroids decreases the vasogenic edema? So multiple mechanisms are there. It decreases the endothelial permeability by upregulation of the occludin and dephosphorylating occludin and zona-occludens 1, thereby decreasing the endothelial permeability, strengthening the endothelial membrane. Then it causes repression of NF-κB, which is a pro-inflammatory cytokine. This inhibition of cytokine-induced barrier breakdown and expression of cell adhesion molecules. Then the other mechanism is non-transcriptional regulating mechanisms, which may be a rearrangement and tight binding of VE cadherin to the cytoskeleton. So the dosing for dexamethasone, the optimal dosing is not yet established, though it is routinely used. So in a case, if the patient has presented in an acute presentation, usually the initial dose may be 10 to 20 milligram initial dose. And there are situations when the daily dose has reached up to 100 milligram per day. However, the usual maintenance dose usually is around 4 to 24 milligram in a divided doses, usually 6 hourly. And the neurological improvement will occur within 48 hours. So ideally, an individualized dosing has to be instituted based on the neurological condition of the patient, the size of the tumor, the edema, and the associated mass effect. And regarding tapering the steroid, the tapering should be started as soon as clinically acceptable. Once there is improvement in the neurological condition, the tapering can be started. Tapering can be started, keeping an eye on the neurological symptoms of the patient also. So various guidelines are there. The American College of Radiology, BC Cancer Agency, and Australian Cancer Network. They usually, according to American College of Radiology, patients with minimal neurological symptoms recommend starting either with 4 to 8 milligram dexamethasone daily or with 16 milligram dexamethasone daily. But you have to taper after a few days. In all cases, steroids should be tapered as clinically indicated and tolerated. The Alberta Provincial CNS team members recommend a maximum starting dose of 16 milligram daily, administered in 4 equally doses for symptomatic patients after biopsy or surgical resection. So this is an algorithm by Alberta Provincial CNS tumor. So after the surgery, dexamethasone may be continued at 4 milligram 6 hourly. Patients who is taking medical chemotherapy or radiotherapy. So after that, we can taper the steroids. There are different methodologies are there. Either you can go for a slow taper or fast taper. In slow taper, you can decrease dexamethasone in 4 mg to twice daily for the first week, then to 2 milligram twice daily for the next week, 1 milligram twice daily for the next week, and 1 milligram daily for the 7 days. And then we have to see whether the patient is symptomatic or no. If not symptomatic, we can continue. Or in fast taper, dexamethasone, we can taper 4 milligram 6 hourly. We can taper immediately to 4 milligram twice BD for 3 days, and then discontinue dexamethasone, and you reassess the patient. So next is the role of steroids in acute bacterial meningitis. So studies have shown that the extent of inflammation of the meninges and the subarachnoid space is related to related to the outcome with bacterial meningitis. So though antibiotic therapy treat the bacterial meningitis is associated with significant neurological damage. So like hearing loss, cognitive impairment, or focal neurological deficit. So steroids, by virtue of its anti-inflammatory action, they may have a role in acute bacterial meningitis. So they can be used as an adjunctive therapy along with antimicrobial therapy. So this Cochrane review in 2013, which included 25 RCTs, around a total of 4,121 bacterial meningitis cases were included. What they found was that there was reduction in hearing loss and other neurological sequelae in participants in high-income countries. However, there was no effect on mortality with dexamethasone therapy. However, in the subgroup analysis, what they found was that there was a significant mortality reduction in pneumococcal meningitis. And also they found that reduced severe hearing loss in children with Haemophilus influenza meningitis. And this one of the adverse event was that in patients who are receiving dexamethasone, there was an increased rate of recurrent fever also. So the UK Joint Specialist Society guidelines for dexamethasone therapy is in acute bacterial meningitis is usually, so 10 milligram dexamethasone or 0.15 milligram per kilogram dexamethasone should be started 6th hourly, should be started on admission either shortly before or simultaneously with the administration of antibiotics, around 10 to 20 minutes before the administration of antibiotics. And if antibiotics have already been commenced, 10 milligram IV dexamethasone every 6 hours should still be initiated up until 12 hours after the first dose of antibiotics. And if pneumococcal meningitis is confirmed, then dexamethasone should be continued for 4 days. And if another cause of meningitis is confirmed, the dexamethasone can be stopped. So next is coming to tubercular meningitis. So the basic principle is that it reduces the meningeal inflammation and the arachidonitis. So this was a study by Thwaites et al., the Vietnam study, where they recruited 545 patients with tubercular meningitis. The dose they used was 0.4 milligram per kilogram per day for the first week, then 0.3 milligram for the next week, 0.2 milligram per kilogram per day, and 0.1 milligram per kilogram per day for the fourth week. Then they used an oral treatment for 4 weeks, starting at a total of 4 milligram per day, and they decreased by 1 milligram each week. What the observation was, there was a reduced risk of death at 9 months, and and also it was not associated with a significant reduction in proportion of severely disabled patients among survivors in the dexamethasone group. So a Cochrane review in 2016 also reaffirmed that. So dexamethasone has a mortality benefit. They reduce the risk of death by a quarter at 2 months to 2 years after treatment was started. And corticosteroids make little or no difference to the number of people who survive TB meningitis with brain damage causing disability. So the index TB guidelines for the guidelines on extrapulmonary tuberculosis for India, they also recommend steroids are recommended for tubercular meningitis, and the duration of steroid treatment should be for at least 4 weeks with tapering as appropriate to the patient. And the dose, they are not specifically mentioned the dose. So the dose we can take from previous studies like 0.4 milligram per kilogram the first week, 0.3, 0.2, or 0.1. Then subsequently however, the initial therapy should be for minimum for 4 weeks, and subsequently we can decide on tapering or to continue with dexamethasone therapy in tubercular meningitis. Now, the role of steroids in other CNS infections, in viral encephalitis, they have an unclear role. Limited evidence is available and need more studies. More studies are needed. And with respect to cryptococcal meningitis, steroids are not recommended. Neurocystic cirrhosis with associated cerebral edema, adjuvant therapy is recommended with corticosteroids. And in bacterial brain abscess, if the patient has signs of brain herniation, and they can be placed on a short course of adjunctive steroids. Next is use of steroids in myasthenia gravis. As you all know, myasthenia gravis is an autoimmune disorder, so it can be used as an immunosuppressant. So and steroids or oral corticosteroids form the first line immunosuppressant in myasthenia gravis. They can be used when the patient is still symptomatic on cholinesterase inhibitors, or they need a better symptom control with better symptom control. So most of the studies are from observational studies, and there is limited evidence from randomized control trials. They suggest that corticosteroids offer short-term benefits compared with placebo, and limited evidence from randomized trials does not show any difference in efficacy between corticosteroids. So usually orally prednisolone is being used, and the clinical response usually appear within 2 days to maximum of 2 weeks, and the maximum response will be attained between 6 months to 2 years. So the dosing regimes for steroids, there are two dosing regimes, high dose regimes and low dose slow titration regimes. The high dose regimes, the problem with the high dose regime is that it can worsen the weakness. So there can be always a risk of myasthenia crisis with high dose regime. So this patient should be monitored for any respiratory complications in the ICU. So high dose regime is usually 1 to 1.5 milligram per kilogram of prednisolone. The 60 to maximum 100 milligram per day is started. Then in coming to low dose slow titration regime, it is here they started at a low dose, usually at 10 milligram per day, and it is gradually increased every 5 to 7 days, titrating to the patient clinical improvement, and the maximum dose is around 100 milligram per day. Now the role of steroids in Guillain-Barré syndrome, usually steroids are not recommended. Corticosteroids do not significantly hasten recovery from Guillain-Barré syndrome or affect the long-term outcome. Oral corticosteroids delay the recovery, and intravenous corticosteroids given in combination with intravenous immunoglobulin might hasten the recovery also. Now, coming to role of steroids in acute spinal cord injury, the American Academy of Neurological Surgeons recommendation, the administration of methylprednisolone for the treatment of acute spinal cord injury is it is not recommended. So basically, there is no class 1 or class 2 evidence for the clinical benefit of methylprednisolone. Whatever benefit we got from the studies, basically the NASIS trial is from the subgroup analysis. So these are mainly class 3 evidence claim inconsistent effects likely related to random chance or selection bias. However, there are class 1, class 2, or 3 evidence exists that high dose steroids are associated with harmful side effects, including death. So basically, 3 trials were there assessing the role of methylprednisolone for improving the motor function after an acute spinal cord injury. The NASIS 1 trial, 2 trial, and the NASIS 3 trial. So NASIS 1 trial, it was comparing a high dose regime with a low dose regime. However, the low dose regime was 100 milligram per day, and the other was 1000 milligram per day. However, there was no treatment, no significant difference in no treatment effect at 6 weeks and 6 months post injury, and the wound infections were significantly higher in high dose group, and the follow-up study also after 1 year also there was no significant difference in neurological recovery of motor or sensory function. The NASIS 2 trial, it was multi-center randomized placebo control comparing methylprednisolone to naloxone and placebo in 87 patients. There was no difference between the groups in all primary comparisons. However, the post-hoc analysis revealed that there was improvement in motor and sensory scores at 6 months in patients given methylprednisolone within 8 hours of the spinal cord injury. And at 1 year follow-up, the post-hoc analysis showed that there was improvement in motor scores, but the sensory scores improvement was not significant. Then in NASIS 3 trial, they compared between 24-hour methylprednisolone administration to 48-hour methylprednisolone administration, along with 48-hour triglyceride mesylate administration. So there was no difference between the group in primary comparisons. Here also, the post-hoc analysis showed improved ASA motor scores at 6 weeks and 6 months in 48-hour methylprednisolone group compared to 24 methylprednisolone groups. Now, in use of steroids in traumatic brain injury, the Brain Trauma Foundation guidelines recommends against the use of steroids, and steroids are not recommended for improving outcome or reducing ICP. In patients with severe TBI, high-dose methylprednisolone was associated with increased mortality, and it is contraindicated. So this is based on MRC Crash 1 trial. They studied around 10,008 patients with traumatic brain injury who were recruited within 8 hours. Methylprednisolone 2 gram over 1 hour was given, followed by 400 milligram per hour for 48 hours. What they observed was the 2-week mortality was higher, significantly higher in the corticosteroid group. The 6-month mortality and the 6-month mortality of severe disability was also higher in the corticosteroid group. Now, role of steroids in posterior reversible encephalopathy syndrome. So basically, PRES, it's an vasogenic edema. So multiple causes are there. It can be seen in an hypertensive crisis, hypertensive encephalopathy and acute blood pressure fluctuations. So this can be due to a hyperperfusion and autoregulation impairment. And studies of multiple case reports are there where PRES is associated with the normal blood pressure also. So it can be seen in from other autoimmune conditions, and it can be seen in patients with immunosuppressive drugs and corticosteroid drugs also. So there are case reports are there where there is a temporal association between steroids and PRES, and there are still case reports where steroids are being used for treatment of PRES also. So the role of steroids in PRES is unclear. How the treatment should be based upon the etiology. If there is steroids are there, steroids are a precipitating factor for PRES, we can consider discontinuing steroids. Now, the role of steroids in acute ischemic stroke, there is no role for steroids. It should not be administered for the treatment of brain swelling complicated in acute ischemic stroke. However, in the management of angioedema associated with IV altiplase administration, methylprednisolone 125 milligram IV is recommended. In intracerebral hemorrhage, corticosteroid should not be administered for treatment of elevated ICP. Now, another condition is in Addisonian crisis. This occurs in patients with adrenal insufficiency. So what we more commonly seen in a neuro IC will be a secondary adrenal insufficiency, basically due to head injuries or after a pituitary surgery or radiation, CNS infection, or maybe a pituitary apoplexy or Sheehan syndrome. Or in drug-induced adrenal insufficiency, or patients who are on chronic steroid therapy for some autoimmune conditions, they may, when there is an acute precipitating event like infections, they can go in for Addisonian crisis. So usually Addisonian crisis is an emergency situation. They present with dehydration, hypotension, or shock out of proportion to severity of current illness. They may have nausea and vomiting, and they may present with acute abdomen also. They may have hyponatremia, hyperkalemia, or hyperpigmentation or vitiligo. This is seen in patients who have a primary adrenal insufficiency. So in the management is emergency. So in the management, we have to give intravenous hydrocortisone 100 milligram immediately and every 6 hours. And once the patient is stabilized with IV fluids, then we can taper glucocorticoids to a maintenance dosage or the physiological dosage over a period of 1 to 3 days if precipitating or the complicating illness permits. Now, the role of steroids in care of potential organ donor. In cases after brain death, there will be a significant systemic inflammatory response that can affect the various organs. So glucocorticoids may have a role because of its anti-inflammatory action, may have a role in patients who are a potential organ donor. So there is something called as combined hormonal therapy or triple therapy, which includes methylprednisolone 15 milligram per kilogram every 24 hours, or 250 milligram bolus followed by 100 milligram per hour till organ retrieval. So here methylprednisolone is used along with vasopressin, 1 unit IV bolus followed by 0.5 to 4 units per hour infusion, along with T4, 20 microgram bolus followed by 10 microgram per hour infusion. So some studies have reported it may improve both hemodynamic stability in brain dead patients as well as the quality of the procured organs. The United Network of Organ Sharing in United States suggests a substantial benefit of triple hormone therapy with minimal risk, and multivariate logistic regression analysis of 18,000 brain dead donors showed a significant increase in kidney, liver, and heart utilization from donors receiving the triple therapy, and significant improvement in 1-year kidney graft survival and heart transplant patient survival were also demonstrated with triple therapy. So this is the Canadian guidelines. So they recommend combined hormonal therapy in donors with an ejection fraction in patients with when they have injection fraction less than 40%, and consideration should be given to its use in all donors. However, it is not a strong recommendation. Not a strong recommendation. The Indian guidelines. So in the maintenance of care of patients, when we are unable to maintain the hemodynamic goals, with systolic blood pressure more than 100 with the first line drugs. The first line drugs include vasopressin, then noradrenal and all. Then we have to suspect an hormonal deficiency. So here we have to replace hormonal replacement therapy has to be given. So it has to be given with vasopressin, methylprednisolone, thyroxine, and insulin. Now, high-dose steroids reduce brain death-induced inflammatory cascade. They improve donor organ quality and graft function. And studies have shown that they have a beneficial role in lung transplant also. They give improved oxygenation and reduction of extravascular lung water and increased lung yield. So the American guidelines recommend high-dose corticosteroid administration reduces the potential deleterious effects of inflammatory cascade on donor organ function following brain death. Ideally, it should be administered after blood has been collected for tissue typing, as it has the potential to suppress human leukocyte antigen expression. So steroids have a definite role in many neurological disorders. However, steroid therapy is associated with significant adverse effects, and early tapering is needed once the clinical effects are achieved. And whenever the patient is in chronic steroid therapy, the side effects, the patient should be monitored for the side effects. Thank you, sir.
Dr. Jerry, it was an amazing and fantastic lecture. The way you put forward the summarized the use of steroids and neurocritical care. It's amazing, man.
Thank you,
It's
sir.
fantastic. So good. Thank you so much, Jerry, for coming and joining
Thank you,
this
sir.
classroom and
Thank you, sir.
making it very, very, very interesting and very, very, very nicely summarized, Jerry. Hats off to you. Yeah, good. So with this, we'll close the session, and
Yes, sir.
we'll take up the comments in the WhatsApp chat or classroom chat. Yeah.
Yes,
Thank
sir.
you. Thanks for all
Thank you,
for
sir.
watching this.
Thank you, sir.